All right, let's jump right into this explainer and demystify the big three of childhood gastrointestinal distress. Today, we're focusing on acquired and functional disorders of motility. And really, when you think about motility, it's all about momentum, right? It's how the body manages that constant flow of food and waste. So when that momentum gets thrown off track, well, it causes some pretty significant distress for the child, and we need to know exactly how to step in and restore that healthy balance. To make sense of all this, we're going to tackle these motility disorders symptom by symptom. We'll be covering diarrhea types and causes, management and prevention. Then we'll look at constipation across different age groups, how to break the constipation cycle, and finally, vomiting, causes and care.
First up, diarrhea types and causes.
So the absolute biggest dividing line when you're diagnosing diarrhea is the timeline. Think of acute diarrhea as sudden and usually self-limiting. It hits fast and it's mostly tied to some kind of infectious agent. But then you have chronic diarrhea. The magic number to remember here is 14 days. Once a child's symptoms cross that 2-week threshold, that's our cue to start looking away from your run-of-the-mill simple infections. We really have to pivot and start investigating systemic conditions. We're talking things like malabsorption syndromes, inflammatory bowel disease, or maybe even underlying food allergies. Now, digging a little deeper into those chronic cases, there are two really specific definitions you need to know. First is intractable diarrhea of infancy. This hits in those critical first few months of life, lasts way beyond 2 weeks, and just stubbornly resists treatment. It's tough. Then there's chronic non-specific diarrhea, or CNSD, which is honestly incredibly common in toddlers. What's absolutely fascinating here is that these kids, they grow perfectly normally, no signs of malnutrition whatsoever. So what's the trigger? Well, usually it boils down to poor dietary habits. Specifically, we're looking at way too much juice and those artificial sweeteners like sorbitol that are crammed into so many commercial drinks. So believe it or not, sometimes fixing the entire problem is literally just about adjusting what's inside their sippy cup. Going back to those acute infectious culprits for a second, they basically fall into two camps, viral and bacterial. Historically speaking, rotavirus has been a massive, massive factor. It's sneaky because it often brings a mild to moderate fever and vomiting before the diarrhea even shows up. Norovirus is the other big viral player you'll see. Then, over on the bacterial side, we've got pathogens like Salmonella. This one totally spikes in the summer, and you'll often see it linked to undercooked meats or, surprisingly, household pets. Yes, turtles and hamsters can totally be the culprits. We also deal with E. coli and Shigella, which are particularly nasty and can cause really severe cramping and bloody diarrhea. Okay, moving right along to diarrhea management and prevention. So you might be thinking, when exactly do I need to test a kid presenting with all this? Well, here's the absolutely crucial takeaway. Extensive laboratory evaluation is actually not indicated for most children with uncomplicated diarrhea. Since the vast majority of these illnesses are totally self-limiting, you really don't need to run routine labs unless the child is showing signs of severe dehydration that actually requires IV therapy. Less is often more here. Having said that, there are some major red flags that 100% dictate testing. For instance, if you happen to discover neutrophils or red blood cells in the stool, that points straight to bacterial gastroenteritis or inflammatory bowel disease, and that definitely means it's time for a stool culture. Or providers might pull out a rapid ELISA antibody test to confirm things like rotavirus or Giardia. Oh, and this is a big one. If the child has any recent history of antibiotic use, that needs to be an immediate trigger to test for C. diff toxin. Why? Because those antibiotics can basically wipe out the normal intestinal flora, throwing the doors wide open for that specific bacteria to completely take over. Now, when it comes to managing that dehydration, our absolute best tool is oral rehydration therapy, or ORT. I mean, pretty much every major worldwide health organization flags ORT as the #1 treatment of choice. These solutions are brilliantly designed to enhance the reabsorption of sodium and water right in the intestines. It is vastly safer, way less painful, and frankly significantly cheaper than hooking a kid up to IV hydration. We really only want to escalate to IV therapy if a child is severely, severely dehydrated or if they just literally can't keep anything down orally. Let's shift gears now. Up next is constipation across age groups. 24 to 36. Keep those numbers in your head. That is the absolutely critical window of hours right after birth. Any healthy newborn infant should be passing their very first meconium stool within this specific time frame. It's basically their first big motility test. But if that 24 to 36-hour window comes and goes without a bowel movement, we have to immediately jump into action and assess that infant for some pretty serious organic and structural disorders. We're on the lookout for things like intestinal atresia, which is basically a complete blockage or narrowing of the intestine. We also need to screen for Hirschsprung disease. If you're not familiar, that's a congenital anomaly where the intestine is literally missing ganglion cells, leading to a massive mechanical obstruction just because there's zero motility there. Oh, and another huge red flag to watch out for is a meconiumylus. That's a blockage in the distal small intestine caused by abnormal meconium. And you know what? That is very often the very first clinical sign we see of cystic fibrosis. All right, let's look at breaking the constipation cycle. So, as kids get older, those underlying structural issues we just talked about mostly give way to environmental and behavioral factors. And this often snowballs into a really vicious psychological cycle, especially for toddlers. Picture this. It usually kicks off with just one really painful bowel movement. Because of that sharp discomfort, the child gets scared and deliberately decides, nope, I am withholding this stool. Over time, as they hold it in, their rectum actually physically stretches out to accommodate all that accumulated stool, and the natural urge to go just fades away. But obviously, eventually it has to come out. And because that stool has been sitting there getting larger and harder, it is incredibly painful to pass. And guess what? That brand new pain completely reinforces their fear, guaranteeing they're going to try to withhold it again the next time. It's a brutal loop.
Because of that exact withholding loop, the vast majority of childhood constipation is actually considered idiopathic or functional. That just means there isn't some scary underlying systemic disease causing it. Instead, it's entirely a mix of environmental and dietary stuff. We're talking transient illnesses, those avoidance behaviors we just broke down, a sudden drop in fluid intake, or maybe just a diet that's seriously lacking in fiber. But hey, there's really good news here. By actively managing their diet, bumping up the fiber and the fluids, and helping them establish a solid routine bowel habit, we can absolutely intervene and break this cycle for good.
Moving on to our final symptom, vomiting, causes, and care. Essential nursing care for a kid who's vomiting really hinges on a few super practical protective steps. Sometimes the cause is just improper feeding, and simply teaching better techniques clears it right up. But in the moment, your absolute immediate priority is structural. You have to position that child upright. We literally cannot risk them aspirating that emesis into their lungs. Another critical, yet honestly frequently overlooked step is oral care. It is so important to brush the child's teeth or at least thoroughly rinse their mouth out after they vomit. You want to dilute that incredibly harsh hydrochloric stomach acid right away, before it has a chance to sit there and eat away at their tooth enamel. Now, what if behavioral tweaks and oral rehydration just aren't cutting it? Or what if the kid simply can't keep anything down orally? That's when medications enter the chat. The modern gold standard of care here is ondansetron, which you probably know better as Zofran. We highly prefer it nowadays because it has way fewer adverse effects compared to those older antiemetics like promethazine and metoclopramide. Those older generation drugs were notorious for carrying nasty risks. We're talking severe drowsiness, irritability, and even these really alarming dystonic reactions where the child's muscles would just involuntarily spasm. Nobody wants to deal with that on top of everything else.
Ultimately, the crucial point we just keep coming back to across all these motility issues is observation. It all starts with you, providing a hyper-accurate assessment of the type of vomiting, the exact appearance of the emesis, and how the child is behaving. That is exactly what gives the physician the clues they need to nail down a true diagnosis. Your keen, real-time observation literally drives the clinical interventions that are going to stabilize that child and prevent severe dehydration.
And that brings us to the end of this explainer. You are now armed with some seriously structured knowledge. From spotting the danger signs of that toddler withholding loop to really leveraging the incredible safety and power of oral rehydration therapy, consider how these targeted strategies actually empower your daily practice. So, here's my final question for you. How are you going to use these specific insights to confidently break the cycle of childhood GI distress and help restore balance for the kids in your care? Think about that next time you're on the floor. Thanks so much for learning with me today.